What I think is important is to recall some perspective on how it is that we achieve health outcomes, how people as individuals and as communities reach health outcomes. And as we know, some of our health is maybe predetermined. There's certain genetic factors that predispose us to one thing or to another. But there are many things that are within our control. And some of you may have seen a version of this diagram from the University of Wisconsin that tried to help us articulate those factors that are within our control and make us aware of how many of them are really social and environmental. Okay? And what this diagram does is it says that we can influence health outcomes through programs and policies that in some way influence what you might call health factors related to those outcomes. But those factors are a product of a combination of health behaviors, which are individual, and clinical care, which usually get talked about, as well as social and economic factors and the physical environment, which we're talking about today. Very often the conversation about how do we achieve better health quickly turns to how can we improve the healthcare system. Okay? But the healthcare system, by good estimation, perhaps can explain about 20% of what we see happening up here. So clinics, doctors, healthcare professionals could get as good as they possibly could be and still would only affect about a fifth of the affectable factors related to health outcomes. If people change their lifestyles, it can make a huge difference, but still potentially only affect about 30% of the change that we would want to see in health outcomes. People can do all they can, but if the environment doesn't change to respond to that, there are limits that are placed on what individual behaviors can do. And therefore, the importance of today is to think about some of these contextual social and economic factors and physical environment factors that very critically shape health outcomes in our communities. So keep that in mind as we go throughout this morning. Let me bring up a little bit more information, again, just to set the context. One thing is life expectancy, which illustrates the importance of what we're discussing today. Life expectancy in the Twin Cities region differs by race. There are disparities. You can see from this chart that if you're an American Indian, you're likely to live about 22 years less than an Asian person, almost that much less than a white person. You can see the other differences for African Americans, for example, relative to whites. Life expectancy is higher in areas where the poverty rate is lower. Study we completed for Blue Cross Blue Shield Foundation, maybe some of you attended the seminar last fall, we showed that if you're living in a neighborhood with a high poverty rate, your life expectancy is much lower than if you're living in a neighborhood with a low poverty rate. And you can see that from these bars. Racial disparities also clearly show up with respect to mortality. What this graph shows, first of all, is as you move from neighborhoods defined by zip code that have high rates of poverty or high income or low incomes to neighborhoods that are different, you see a definite trend and change in life expectancy. Actually, this is death rates, sorry. The death rates in areas with low incomes are higher than those in areas with high incomes. You can see that trend. Within that trend, what this graph also shows is that those rates are higher, for example, for American Indians and for blacks at every level of income. The interesting thing often referred to as the immigrant paradox is that Asians, for example, tend to have very low mortality rates even in neighborhoods with low incomes. What's important about understanding these disparities is that Minnesota's population of color, those most likely to have the low life expectancies, the high mortality, have grown considerably, especially in the past couple decades, as you can see from this graph, and you can go on our Compass website, see this graph as well as other variations of it. And poverty is greater for persons of color. As this graph shows, the poverty rate for persons of color exceeds that for whites, and in fact, as many of you know, in Minnesota, the disparity between whites and persons of color is greater, it's worse, than for the nation as a whole. Addressing inequities, as we discussed at our forum with Blue Cross Blue Shield Foundation, is an issue of justice for our region. It's also a very important ingredient of cost containment and long-term regional prosperity. So if we're concerned about financing the healthcare system, sustainability of that system, if we're concerned about long-term economic development, regional competitiveness, we have to address disparities. And the obesity issue clearly exists within that realm of disparities that we need to address. This graph, taken from an article that appeared in the New York Times a few months ago, looks at trends in overweight as well as obesity in all of about 30 to 35 countries who are tracked annually by the OECD. And what you can see in this particular graph, where they just pulled out about 6 or 7 countries, is that the United States has been consistently at the top and has consistently risen. In fact, there's only one other country that has a higher rate of this, and now remember, this is combined overweight and obesity, only one other country with a higher rate than the United States. Anybody know what that is? Mexico. So, to get to a conclusion, first of all, keep in mind the importance of those social determinants of health. Secondly, keep in mind significant disparities that exist in our community and which to some extent are worse than anywhere else in the nation. Third, remember we have to focus on the social environment in order to address the obesity issue as well as many other health outcomes. There's only so much the formal system can do, only so much that individuals can do through changes in lifestyle if the overall context environment parameters aren't changed. So moving forward, it's important to understand what we can and cannot change. It's important to work at multiple levels, from national to local, and there will be some discussion of that today. And at the local level, it's very important to draw upon the experience, the knowledge of community members, and to support community groups to lead interventions that incorporate the best scientific evidence that we have, blending community research with evidence-based practice.